I'd like to welcome in our first guest in the program today, Carolyn Pare, President and CEO of Minnesota Health Action Group. And Carolyn is going to talk about a very important topic in the marketplace, and that's the rising specialty drug prices. Carolyn, good morning.
Good morning.
Hey, nice to have you coming to us from Minnesota today. How is it in Minnesota today?
Well, it's actually sunny and hot here in Minnesota, and we only get about 3 days like that, so let's hurry up so I can get outside.
There you go. Carol, again, it's nice to have you in the program. Tell our audience that may not be familiar with Minnesota Health Action Group about your organization, and then we'll start talking about specialty drugs here in a minute.
Well, we're an organization that came together back in the late 80s. Just a couple of big businesses here based in Minnesota got together and wanted to talk about how they were providing benefits to their employees. And as a result of that conversation, the conversation got bigger. And in 1992, they created their own health care program. So a number of big employers in the city got together and offered a benefit program that was the same across all those employers and really forced some significant market changes here in Minnesota. The group has stayed together, though we're not running that program anymore. We've stayed together in order to affect significant change in the healthcare space so that people can get the right care at the right time in the right place. So we are the stewards of the dollars that our employees spend on health care, and as such, we're doing all that we can to make sure that it's effective in how they spend that money.
Yeah, and one of the big pain points in the marketplace, no pun intended there, is this rising specialty drug cost problem. And talk a bit about the size of this problem, and then we'll talk about some things that you guys are doing.
Well, specialty pharmacy has been around for a while, so there have been drugs that have been used for treating very complex conditions like multiple sclerosis, cancer, rheumatoid arthritis, and hemophilia. So they've always been an issue with employers because they've been expensive. The concern right now, though, is because they used to be relatively limited in terms of their occurrence in employer populations, while they were very expensive, there just weren't very many of them. Well, what we're seeing now is new drugs that are coming out and that will treat bigger populations, so much broader use. So I think the first notice that people got was when the hepatitis C drug was introduced at what I will say was an incredibly outrageous price of about $84,000. People started to take notice because 3 million Americans are estimated to be infected, and less than 1/4 of those have been diagnosed. It's gotten even scarier with a drug that hasn't yet been approved by the FDA, but approval is expected sometime this summer, and they're called PCSK9s. What they treat is high cholesterol. Now, when you think about high cholesterol, you've got a population of about 15 million Americans that have high cholesterol, and depending on how these drugs are prescribed, who they're given to, they're estimating right now that the total annual cost for this class of drugs could be as much as $200 billion. Now compare that to the Hep C drug that we all panicked about. That's about an annual cost of $15 billion. So this one will be something we can't even imagine.
Wow. Carolyn, just backing up a little bit, and then I have a question about the specialty drugs. The Minnesota area has been a hotbed for healthcare for a long time, with really innovative thinking both on the employer and the provider side and even the carrier side. United Healthcare being up there, Mayo Clinic. What is it about Minnesota that people stay so focused on creating innovative ideas around healthcare?
Well, sometimes I like to joke and say it's because it's cold so much of the time that we're stuck inside looking at each other, so we have to talk about things. I don't know that that's the case, but the reality is we have always, and I've been proud to be from here. It's unfortunate that people think we're a little weird. They call us Planet Minnesota because we seem odd. I think a lot of the things that we do here in Minnesota can be done everywhere. It's a matter of political will and interest in really resolving common problems that affect us all. So we've had this active group of employers, for example, since 1988 that have very strong connections with the provider and health plan marketplace, and we continue to collaborate on issues so that we can innovate collectively because the entire supply chain affects us all. We are all part of that supply chain, from the buyers that are employers to the providers that provide tertiary care. So we have to work on things together.
Well, you have been a very creative community in a lot of different ways that the rest of the country can look at as models and examples of what to do. But on especially drugs, let's talk about that for a second. A lot of the discussion around it maybe scares a lot of potential users that there's something that they need that because of the cost, somebody might be trying to restrict. How do you validate whether some new drug is in fact value-based? It gives a marginal improvement in the quality of life or in the potential for cure relative to the cost, or is it all about cost savings?
Right now, there's not a lot that can tell us exactly how these drugs are going to perform, which is something that makes it scary. And so one of the recommendations that we would make as a group is that we do have organizations or groups that will evaluate these in terms of their value, because right now it's difficult to put a tag on the actual value. And as part of our learning network that we've done with our members here, we talk to ethicists to talk about this, because this is the first time that we really have to face the issue of offering a drug for $500,000 to one person who might get marginally better for 3 more months of life, or a $1,000 drug to 500 people. We need to start thinking about this in a value-oriented kind of way, and I don't want to sound hard-hearted, as none of our employers are hard-hearted, but the fact of the matter is we just can't afford to pay for these drugs the way they're priced and distributed right now. We just can't.
Is it the pricing, or is it the development of the cost that runs it up? I mean, there's a market value there for improvement, but is it the development cost that it takes to get to market? Why are these things costing so much? What's the high price, or the ingredients or the process to create the drugs that's driving up that potential price, or is it just perceived that it's just all profits for the pharmaceutical industry?
Well, I think that there are challenges, because when you say it's all about profits for the pharmaceutical companies really bristle and will come back and say it's the price of innovation. But the reality is, what we've seen is whenever the pharmacy company wants to justify the cost for a particular drug, they'll compare it to something like, if this particular condition was left untreated, ultimately something horrible will happen, like a liver transplant, and that will cost you a ton of money. Those I would characterize sometimes as somewhat fictional. The reality is the drug company then will say, we'll price the drug at 10% less than that worst-case scenario outcome. And then, through the supply chain, there's all sorts of different markups and shell games that are played, because different entities are taking different portions of that cost and, of course, growing their margin as well. So there's just the lack of transparency in the cost of the drug and how the distribution channels affect that cost of the drug before it gets to the patient is something that really limits our ability to understand, again, going back to your question about value, to understand the value relative to its potential outcome. I really think we need to challenge the transparency of pricing on these drugs, what it takes to take it to market. Our employers can't understand why you can get this drug, let's say the Hep C drug as an example, why you can get it in Europe for $24,000, in India for $900, and here you can't touch it for less than $84,000.
Carolyn, how is that from your employer groups and others? How is this growing as a percent of their healthcare costs, and even comparing it to specialty versus traditional pharmacy?
Well, right now, on average, the percentage of drug spend out of, let's say, total healthcare expenditures is about 10%, right? Now, that's not really accurate, because when employers look at their drug spend, they're typically looking at what's paid out under the pharmacy benefit, but the cost of specialty drugs are actually covered under both the pharmacy benefit as well as the medical benefit. So that adds some more money to it. And so overall, the cost of the drug spend in proportion to total healthcare spend runs more like around 18%. Now, in our most recent survey of our Minnesota employers here, the drug trend, so just put this in perspective, drug trend for generics was 12% in this past year. For brand, 4%, and specialty, 30%. So if you're looking at an overall healthcare trend, which is pretty low right now, 42%, but you throw on that specialty is growing by 30% a year, the cost of drugs will overwhelm our healthcare expense. And I have one other quick fact that we've learned along the way through this learning network. In 2012, as a country, we spent about $80 billion on specialty drugs. By 2020, the projection through the Office of the Actuary is about $402 billion. Now, put that in context relative to total healthcare spend. By as soon as probably 2018, we'll be paying more for pharmaceuticals than we'll be spending on physician services. And if I was a doctor, I'd be nervous about that.
Yeah, well, now you just alluded to it. I mean, this is a big, complicated problem and a real challenge for employers. And you've created a specialty pharmacy learning network to help employers. Tell us more about that, please.
Well, the Action Group's done a number of what we call care delivery learning networks, where we look at at areas of particularly high cost and overuse. We've looked at maternity and infertility, back pain and spine surgery, hip and knee replacement, and then, based on what our employers were interested in, and specialty pharmacy was huge, we decided to do one on specialty pharmacy. Typically, through a learning network, we bring in key informants from the marketplace to teach us what's going on in this particular area. We were very lucky to secure the guidance of a professor at the University of Minnesota named Stephen Schondelmeyer, who's world-renowned in this particular space. He's served as our advisor through this entire project. What we recognized quickly was that since this area was so incredibly complex and was evolving daily, there were new things that we were discovering daily, we couldn't complete our learning network in just 6 months. So we did a phase 1 learning network where we took in a lot of information. We spent hundreds of hours, quite frankly, between all of us on better understanding what's going on in this space. And then we decided we needed to do a phase 2. So the first phase would really be about learning, but phase 2 has to be about mobilization, because if we don't do something right now as the market's developing, we will become yet again victims of something that is totally irrational and ridiculous.
So the idea of what you're doing is not where you could put restrictions on the use of the drug or the prescribing of the drug, but giving both patients and employers who are engaged information on more effective drugs, or at least as effective drugs that are less costly, that a patient might find more attractive to use if they're otherwise going to be using part of their own out-of-pocket expenses to cover some of this. Is that so? You can't really stop this once it gets FDA approval. You just have to educate to guide people to better choices. Is that the thrust of what you're doing?
Well, there's a number of different ways that we're working on this. One clearly is the education of the consumer piece, which I understand is so very important to you. Just understanding how we create and craft those messages so people don't think that we're just trying to limit their access to drugs. This isn't about limiting access. This is about making sure that the right person gets the right drug that's going to work for them. And so there has to be some education on behalf or for employees and their family members so that they understand what's going on in this particular area. We aren't right away suggesting that there be substitutions, but clearly we're directing our employers to work very closely with their vendors to best understand how these drugs are best utilized and whether or not they are being utilized in those best practice sorts of ways. One of the things that we've got to get to very quickly is the data and what the data tells us, so that employers can understand how they're actually spending the drugs, how they're being managed by all the different vendors within the process, and how they can more effectively negotiate with those vendors. So not necessarily just pushing it all on the consumer, but ultimately working with the vendors in the supply chain to try to minimize the expense of the drugs. And again, doing the care management, the prior authorization, the step therapy, the things that are needed to ensure that the person is getting the drug they need, and employers again, looking more at the outcomes associated with those drugs for that person. So, for instance, if that person isn't getting better after a certain period of time on that therapy, that something else happens for that person. So it really is a different way to manage this entire area than what we've done traditionally, because these drugs are so complex and they're used and will be used more broadly in the population. We just don't think that these drugs are something like a statin where you just say, oh, we should probably just put them out in candy bowls in the office because they're so good for you, to the point where if you really need this drug because all other drugs have not been effective at resolving your condition, we are supporting you for that, and we will help you get that as cost-effectively and as efficiently as possible. That's really the goal. And one of the things that we've developed is, unfortunately, a 9-page document, which is really a list of all the actions that employers need to take, not only as individual employers, but collectively with other employers, so that we can use our collective voice to influence the marketplace. And then, too, what we need to do on a policy level. What sorts of things do we need to talk to policymakers about in order to stem the tide of the growing costs in this particular area?
Yeah, Carolyn, this has been a very informative discussion, and I really appreciate it. To our listeners that may want to connect with you and find more information, please let them know how they can contact you.
Well, they can go out to our website, and for me, I just Google Minnesota Health Action Group, and you're there. There's a lot of information there. Of course, they can contact me at cperry@mnhealthactiongroup.org, and, I'm around and happy to answer any questions that anyone might have. This is a fascinating area. We're learning so much. Every day there's something new. I'm sure you're seeing it in the media all the time. It's something we really do need to pay specific, careful, and active attention to. So I appreciate you having me on your show.
Yeah, great to have you, and great discussion today. You have a great weekend up there.
Thank you.